Hello and welcome to the second EDI Lunch and Learn Empower Hour session. Today we will be going through neurodiversity in general practice. I'm Shella, EDI Director for General Practice Task Force, and Catherine is our EDI Fellow who is looking specifically at neurodiversity. So I'll hand over to her. Thanks, Catherine.
Hi everyone, thank you so much for joining us for this talk on neurodiversity in general practice. I'm Catherine Bell, I'm a GP and also the Equality, Diversity and Inclusion Fellow with GP Task Force Derbyshire, looking at neurodiversity, as Shella said. So my interest in neurodiversity really began as both a professional and a personal interest. About a year ago, I decided to seek an assessment for ADHD for a number of reasons. And one of those reasons was very much that I didn't see a lot of senior role models with neurodivergent diagnoses, and I thought that it was yet another reason to kind of pursue that for me. At the moment, I'm a year into a 4-year waiting list, so I will not know if I have a formal diagnosis for some time yet, and currently I don't. But I feel like this journey and this kind of learning that I've done relating to neurodiversity has been really, really helpful in kind of moving through my personal journey, but also hopefully I'll have some benefits for other neurodivergent staff working in general practice. So to start with, I'd like to try and raise awareness of neurodiversity in our patients, in our colleagues, and in ourselves. And I hope that by the end of this session, you'll know what's meant by neurodiversity, you'll understand why an awareness of neurodiversity is important for all general practice staff, and hopefully you'll be able to signpost your neurodivergent colleagues to relevant support. So first of all, I suppose, what is neurodiversity? And many of you will be very familiar with that term, but for those of you who aren't, it's similar to the concept of biodiversity, where you acknowledge that there is an importance in maintaining a wide variety of plant and animal life in the environment, just as the term neurodiversity is used to describe the variation in how our brains process information and how we experience the world around us. And it's estimated that 15 to 20% of the population, so that's 1 in 7 people, are neurodivergent. And this term is used primarily to describe people with ADHD, autism, and specific learning differences such as dyslexia, dyspraxia, and dyscalculia. But it also is an umbrella term that covers quite a lot of associated conditions, things like epilepsy, OCD, Tourette syndrome. So there's quite a lot of conditions that are included underneath that term. And in general practice, we're really familiar with the medical model, a deficit-based model used to diagnose psychiatric conditions. And this is just a little example here from the DSM-5 for autism spectrum disorder. I'm just looking at the type of language that's being used there. It's all very much focused around things that people can't do. But we know that a deficit-focused approach to neurodivergent people leads to misunderstanding among professionals. People assume that they are incapable of success, whether that be in education, employment, or socially. And it also implies that neurodivergent people need fixing, which puts an inappropriate focus on the research into prevention and cure rather than supporting individuals and social change. And that's just another example from the ADHD classification. Again, all very negative language and focusing very much on the things that people can't do. So the neurodiversity movement encourages people to see these conditions from a difference-based perspective. And this aligns with the social model of disability, so believing that neurodivergent people are disabled by their environment, and that instead we should be focusing on fixing the disabling social, cultural and environmental factors rather than the person. And this quote says this in a really nice way. So when a flower doesn't bloom, you fix the environment in which it grows, not the flower. And that's very much the focus of the neurodiversity movement. So when we're thinking about neurodiversity from a difference-based perspective, we can also appreciate the many strengths of neurodivergent people. And a differently wired brain can be an innate advantage to some people. So it can help with creativity. Some people experience hyperfocus, so the ability to really focus in on a task and not be distracted by the rest of their environment. Some people are very good at attention to detail. So there's lots of various strengths associated with neurodivergence. And growing up in an environment that's not designed for your brain can also develop your skills in problem solving, make you very determined as an individual, and make you very resilient as an individual as well. And here are just some examples of high-profile, successful entrepreneurs, artists, athletes who are all neurodivergent. So you've got Greta Thunberg there, who's autistic. You've got Simone Biles, Michael Phelps, Olympians who've got ADHD. You've got Daniel Radcliffe, an actor who's got dyspraxia. You've got Whoopi Goldberg, Jim Carrey, who are dyslexic. So you've got loads of role models now coming out and talking about their neurodivergence. And it just shows how neurodivergent people can excel in a supportive environment where their strengths are recognised and nurtured. So I just thought I'd go back to terminology. So when we talk about neurodiversity, that is the range of diversity across the population as a whole. So that's a mix of neurodivergent, so people who have these neurodevelopmental conditions, people, and neurotypical people. So that is the majority group, which is seen as the social norm. So you refer to an individual as neurodivergent and a population as neurodiverse. And within that, you're looking at specific neurotypes and neurominorities with specific conditions. And so hopefully that makes things a little bit clearer. Speaking about language, it's also important to consider what autistic people, how autistic people wish to be referred to. And there's been a lot of work from the autistic community emphasising their preferences more recently. And unlike with many medical conditions, such as diabetes, where there's been a move away from that identity first terminology, so referring to a person with diabetes rather than a diabetic, a lot of studies have shown that autistic people prefer that identity first language because this is part of their identity, and it's felt to be more neuro-affirmative, so supporting of this neurodiversity view. So they prefer to be called autistic rather than a person with autism. And this picture here just highlights a few of the key points. So rather than talking about somebody being high functioning or low functioning, those sorts of labels are often associated with people being denied support. So if you're high functioning, you're being denied, that's a reason to deny you support. They talk about what are your support needs and acknowledge that that level of functioning can fluctuate and you can't put somebody in that category specifically. That might change day by day and depending on their current environment and stresses and so on. So just thinking about the autistic spectrum, that's another area that is sometimes misunderstood, and a lot of people do see this as a very linear kind of spectrum, so either not autistic or very autistic or somewhere along the line, and that's certainly not the case. Many neurodivergent people possess what we'd call a spiky profile, so looking at this spectrum here, if I can point at it, so you've got little points here on here, so somebody might have a really great strength for language skills, but actually really struggles with their sensory overload, and so they end up having this sort of spiky profile, which is less common in neurotypical people who might be more consistent throughout all the domains of their life and their functioning. So just a word about masking. It's another term that you've probably heard of. It's the act of hiding or suppressing neurodivergent traits in order to fit in with a neurotypical society. So examples of that, particularly for autistic people, might be scripting conversations, forcing eye contact, and suppressing what we call stims. So stimming is behaviour that is repetitive movements or sounds that are very comforting and soothing to a neurodivergent person. And often that is something that appears odd to the outside world and they suppress, and that in itself takes a lot of effort. So masking is thought to be a key contributor to burnout and mental illness in neurodivergent people because of that intense conscious or subconscious effort that is required to keep going with the masking in a kind of social environment or work environment. So why is an awareness of neurodiversity in general practice important? I think firstly because we see neurodivergent patients in general practice every day. We've said already that 15 to 20% of people are neurodivergent, which is obviously a huge proportion of our patients. And I think really now that I'm more aware of neurodivergence in my patients, I think that it's likely neurodivergent people consult the GP more often. So there's probably a high proportion in the people that we see day to day. I think it's important to remember that overlap between neurodivergent conditions is the rule, not the exception. So if you have one neurodivergent condition, for example, dyslexia, then you are much more likely to have another one, such as ADHD, autism. And certainly that there is studies to show that if you have a family history as well, you are much more likely to have these conditions. And that might be a family history of dyslexia, and then you're more likely to have ADHD. So there's lots of overlap there. We know that neurodivergent people have high rates of mental ill health, and that's from obviously growing up in an environment that isn't set up for them. There can be a lot of trauma associated with that, and autistic people are 8 times more likely to die by suicide, which is just an awful statistic. And more recently I've heard that for autistic women that can be 13 times more likely to die by suicide, which is obviously huge. Then 30% of patients with substance misuse have ADHD, and also 30% of patients with eating disorders, young people, are thought to have autism as well. So there's a lot of crossover with these other conditions, mental health conditions. But equally, there's also physical health issues, which there's more and more evidence to suggest are associated with neurodivergence, particularly autism. There's more research into that at the moment. So things like central sensitivity syndrome, so irritable bowel syndrome, chronic fatigue syndrome, fibromyalgia, there's thoughts to say that actually this increased sensitivity to bodily sensations and external stimuli, it translates to these conditions. So you're more aware of your bodily sensations and you're more likely to have these conditions, which is really interesting. There's also some associations with hypermobility and autism, which is being looked into at the moment, and things like allergies, atopy and autoimmune disease. There's more and more evidence to suggest that there may be a link between these conditions and neurodivergence as well. So certainly it's something we need to be aware of in our patients. And it's estimated that about 1% of the population are autistic, which is probably a huge underestimate. 3 to 4% of adults may have ADHD, and 10% of people have dyslexia. So these are huge numbers of the people that we're seeing. I also feel like it's important because we work with neurodivergent colleagues in general practice every day. Again, that percentage applies to the staff population as well as the patient population. And we know that because neurodivergence is not associated with intellectual ability, with race, with gender, with social class, you're going to have a spread across the population of neurodivergent people in any environment. So I'd like to focus a little bit on the strengths of neurodivergent staff. I think there's been a lot of interest and research now into neurodivergence as a positive benefit to society. There's certain organisations that are looking at recruiting dyslexic and neurodivergent people specifically for these skills. And in medicine, it's obviously becoming a bit more of a discussion point as well. There has been some research to link neurodivergence to gifted individuals. So some people who have exceptional skills in pattern recognition, in coding, and lots of other areas. And there's been a misconception about how neurodivergent people lack communication skills or lack empathy, which again has been disproven. Often autistic people experience hyper-empathy, so they empathise in such a strong way with people, but not only people, animals, sometimes objects, buildings. They have a huge amount of empathy, and again that can be a challenge as well as a benefit. But it certainly means that neurodivergence is not a reason to avoid a career in a caring profession. And there are increasing numbers of healthcare workers who are being diagnosed in adulthood after years of already working and thriving in medicine, nursing, and all these other allied healthcare professions. So yeah, it's an outdated attitude, and it's rightfully being challenged. Somebody who in particular in the media has been trying to advocate for neurodivergent people is Dr. Mary Doherty, who is a consultant anaesthetist based in Ireland, and she's the founder of Autistic Doctors International, a peer support and advocacy and research organisation. And she's written a lot about how she feels that medicine does actually in fact select for autistic traits. So a lot of the things we value in doctors and in the medical profession, like attention to detail, a good memory, and the ability to focus in in-depth detail on certain topics, these things are valued. And equally, there's been more information about how people with ADHD enjoy environments such as A&E, where there's a constant changing environment, constant changing stimuli, and are very much driven by the urgency and the novelty of those environments. So yeah, there's a lot of more recognition of how neurodivergent healthcare staff are already contributing to the profession, and yeah, there's a lot of strengths that we need to recognise as well as challenges. So this is just some information from a paper that's only just been published, which I thought was really helpful. It's quite a busy slide, I apologise. But it was views of the strengths of neurodivergent people, which they identified themselves, but also the strengths that their employers have observed as well. And you can see there at the top, you've got the creativity, the hyper-focus, the detail processing. Obviously, depending on your diagnosis, you may be better at some of those things than others, but again, it's just showing that there's a lot of strengths that need to be recognised. But equally, we know there are challenges, and I think that, as I mentioned before, the masking side of things is huge. So looking after yourself mentally, you can see there at the top of this bar chart here that is the most challenging, most commonly reported challenge by neurodivergent people in this study. Also, although you may be able to hyper-focus, you may not. You may find that there's a lot of distractions. And you might find looking after yourself physically as well is very difficult. So there's lots of challenges that we acknowledge with these diagnoses. So what can we do about these challenges, and how can we help neurodivergent people? So neurodevelopmental conditions are considered a disability in the UK as defined by the Equality Act 2010. In that they cause an impairment which has a substantial and a long-term adverse effect on the person's ability to carry out their normal day-to-day activities. So neurodivergent people are eligible for reasonable adjustments in the workplace to avoid them being put at a disadvantage. And I think that this is something people commonly misunderstand, is that it's not a case of giving someone an unfair advantage. They are already disadvantaged by their disability. It's about giving them the ability to be on par with their non-disabled colleagues. So rather than equality and letting everyone have the same benefits, it's more about equity, and some people will need more help than others. And just a final graph from this recent paper about neurodiversity at work. This was looking primarily at businesses. I don't think there were any healthcare organisations included in this study, but it just gives you an idea of the sorts of adjustments and things that people can start thinking about on a practice-based level. So looking at flexible schedules or individualised rotas, having a private space, so having for example, for a GP that might be working in the same room every time you're in the practice rather than hot desking, having that control over your physical environment, so the lighting, the sounds, being able to wear noise cancelling headphones when you're doing admin. There's loads of different potential things that you can do at a practice-based level. But then also I'll talk a bit in a minute about accessing specialist support, so coaching, specialist software, and how to go about doing that. So I've got a couple of case studies now, just to illustrate what we're talking about. They're completely fictional, but they are an amalgamation of people I've spoken to or heard from, or learned about during my time doing the fellowship. So this is Jack. He's 18 years old. He's a new member of the reception staff. His mother is one of the GP partners, and he's working on reception over the summer before he goes to university to do a maths degree. He was hired after helping out the secretarial team during his last summer holiday, who were impressed with how quickly he picked up the computer system and how he quietly got on with the job, even suggesting changes to their processes, which made things more efficient. Jack appears nervous about his new role, and you notice him fidgeting constantly. He tells you he's finding the job difficult and that he particularly dislikes being on the front desk, especially since one patient complained that Jack was rude to her when she was trying to book an appointment. When asked about this incident, Jack says that he can't see why the patient would say that, as he was only being honest about the lack of appointments that day. Jack appears agitated after your conversation and leaves work early with a headache. So if you'd like to contribute either in the chat or putting your hand up, why do you think Jack is finding his new role difficult? Do you think he is neurodivergent, and does that matter? I'd love to hear your thoughts.
Sometimes new members of staff just find it incredibly difficult coming into a very busy, very diverse environment, don't they? We know as GPs that the scope of the questions that you can be asked, every 10 minutes we have to focus on something else. And for staff, it's probably every, 30 seconds. So I'm not sure whether he's neurodivergent or not.
No, I think that's a really good point. I think when we're thinking about adjustments and changes, actually all of these things would benefit everyone. It doesn't really matter if you're neurodivergent or not, but to a different extent, people will find that particular environment very overwhelming, and particularly like the sensory overwhelm of a noisy, busy waiting room. Like you say, being bombarded with lots of questions, the unpredictability of it all. It's not an easy environment to work in. So it may just be that. But equally, there is that chance that he is finding it more overwhelming because of an underlying neurodivergence, which is something is useful to consider as an employer, as a colleague in that situation. Any ideas about how we could support Jack with this, or any changes that could be made?
So sorry, Catherine, a couple of people have put messages in the chat. So one participant has said new environment, stressful / busy, and somebody else has said may find challenging socially, the patient contact, may have communication challenges.
Yeah, definitely. And I think that particularly the reception environment, like you say, is such a hugely sociable job, isn't it? You're having to speak to people and communicate with people constantly, and often people who are upset, ill, at the end of their tether. And yeah, it's a particularly challenging environment. So it's possible that there's been misunderstandings or poor communication with that as well. So I thought this would be a good time to talk about the double empathy problem. So you might have heard this term, but it's basically saying that there's acknowledgement that autistic people can find social communication difficult at times, but to kind of reframe that problem as this is not just the autistic person's problem. This is also the non-autistic person's issue, in that they are not understanding and they are misinterpreting the autistic person's communication. And actually, if we all understood more about neurodivergence and autism, then we would understand why they might be reacting in that way, or why they might communicate in this way. So the autistic person might struggle with indirect communication. They might not be able to read between the lines. They might not necessarily pick up on the social cues. For example, if a patient comes to reception and they're extremely upset and angry, they might not necessarily pick up on that when they're discussing appointments. So for example, if Jack was autistic and he had very kind of simply and abruptly told the patient that there were no appointments, he might not have picked up on the fact that this person was extremely upset about that, and he may have come across as rude. Equally, it might not have been the case, but it's just something to think about as a possible cause for why there's been that misunderstanding. And as we said, obviously there's a lot of sensory distractions around that can cause problems with communication as well. And equally, if the patient was very familiar with neurodivergence, they may not have necessarily jumped to the conclusion that he was rude. They may have thought actually his communication style might be more direct. And they may not be able to imagine that sensory overload that he is experiencing in that role. So just thinking about autism in the workplace, I mentioned already about clear communication. These are simple things that can be done to avoid misunderstandings, keeping any routines stable. So we talked about a familiar room, a familiar work schedule, that sort of thing can be really important. And yeah, speaking to the individual themselves and talking about what their preferred communication style is also important. And looking about and understanding what stimming is and why somebody might be doing that, and not trying to suppress that, and understanding it and allowing that person to do that when they have the urge to do so can be helpful for autistic individuals. So my second case study is Jill. Jill is a GP partner in her late 40s who joined the partnership straight after completing her GP training. Before this, Jill trained in another hospital-based specialty, but she struggled to pass the specialty exams, which led to a surprise diagnosis of dyslexia in her late 20s. Despite this, Jill succeeded in her GP exams with extra time and has not felt the need for any formal workplace adaptations. Jill is well liked by both staff and patients. It is known that Jill's surgeries always run late, but patients are happy to wait as she always listens and goes above and beyond to help them. And the reception staff know Jill will always respond if they need a query answering mid-surgery. Outside of work, Jill has 3 children and is a member of the PTA at her daughter's school and a Zumba instructor. She also enjoys knitting and has set up a staff knitting circle. Over the last few months, you've noticed that Jill has not been her usual bubbly self, and she's staying later and later after evening surgery to complete her paperwork, as her clinics are running over even more than usual. When you ask Jill if she's okay, she apologises for not pulling her weight and tells you she's not sleeping well, which she suspects is due to a combination of menopausal symptoms and worries about her daughter, who is having trouble with anxiety and has started refusing to attend school. So what do people think about this situation? Do you think that Jill's neurodivergence, so her diagnosed dyslexia, is relevant to this situation? And if so, how might that be?
Maybe it could be that the stresses, maybe normally under normal circumstances she can cope fine, but it's that additional stress which is the barrier. Yeah.
Any other thoughts? Yeah, I think what you say about stress is really, really relevant. So often neurodivergent adults, people who particularly who have got through their childhood and adolescence without having a diagnosis, have developed very sophisticated and very creative strategies for coping with their difficulties, and actually once their stresses and responsibilities reach a certain threshold and exceed their ability to manage those things, then yes, things can happen and the wheels can fall off a little bit. So certainly those extra stresses in her life could have just, pushed those strategies out the window a little bit, and she's not able to manage with her usual ways of managing.
Yeah, so Catherine, that's echoing exactly what somebody else has already put in the chat. And then another participant has said, yes, I think it could be relevant, dictation software, ?
Yeah, so that sort of thing. She's obviously managed very well without any adaptation so far, but equally, this might be the time to do that and to access some support. So as we said, it's important to remember with neurodivergence that dyslexia is not just difficulties with reading and writing. There are difficulties with sequencing content in documents, so that could be very relevant to writing referral letters, making sure you're getting everything in the right order, and that might take a lot longer because you're struggling with that sequencing. Time management, it can be an issue, again, for surgeries and for managing your admin, finding it hard to concentrate. And sort of processing data, so things like scanned documents might be particularly difficult and need longer. But equally, overlap of these neurodivergent conditions is the rule, not the exception. So we have to consider, does she have more than one neurodivergent condition? Is it possible that she may have ADHD as well? And so she's approaching the menopause, and many women with ADHD notice that their symptoms are exacerbated by hormonal changes. So that might be associated with puberty, pregnancy, postpartum, or the menopause. Particularly in the menopause, the cognitive symptoms can be exacerbated. So that might be another thing to consider for her. Has she got an extra diagnosis there that might require investigation? But also the troubles that she's having with her daughter. Neurodivergent people are more likely to have neurodivergent children, and obviously the challenges that come along with that as well. And studies have shown that if you have ADHD, your children have about a 35% chance of acquiring it, and if a child has it, there is a 50% likelihood that one of his or her parents has ADHD as well. With dyslexia, 49% of parents of dyslexic children also have dyslexia. And with autism, studies have shown that it is a predominantly genetic disorder, with estimates ranging between 40 and 80% heritability. If we do think about ADHD as a potential cause for her difficulties, again, you can see here some of the challenges that she's experiencing, concentrating on tasks which aren't interesting. So sometimes the admin side of things can be more difficult if it's more of a mundane task. Time blindness, so a lack of awareness of the passage of time can be particularly relevant for appointments and timed activities. This obviously leads to more stress and anxiety if you're struggling to organise yourself and your family, and particularly as you have more responsibility, these sort of strategies, as we said, can be exceeded by the number of things and the difficulty of the tasks to be done. So thinking about support, as you said, software, that might be a really good thing for her, but it might be just a start to ask, what aspects of this role are you finding the most challenging, or what aspects of your environment are you finding most challenging, and what can we do as a practice to help with that? It may be that you change the rota, you change the appointment times, you put more blocks in, you might, as you say, look into what other equipment and things you can access, and I'll talk about that in a second. One thing that might be helpful if the person isn't really sure what the difficulty is, it just feels like everything is overwhelming and everything is difficult, is using a sensory or a cognitive profiling tool. So Genius Within is a company that I know is used by the deanery, I believe, for trainees when they're having neurodiversity screening. And they used to provide a free tool, which was really, really good, but now you have to pay, unfortunately. And it's a questionnaire which basically directs you to areas that are strengths and areas that might be weaknesses, and gives you some generic adjustments which might be of benefit to a person in the working environment. So that could be a really good thing to access. But there's also a government initiative called Access to Work for anybody with a disability. And it's important to remember with this one, you don't actually need a formal diagnosis of a neurodivergent condition to access this. You can go to them with your suspicions or your difficulties, and they will assess what areas you're struggling with, independent of a diagnosis. And through that, you can access funding for these workplace adaptations. So if you needed new software, then they would pay for that. They can provide coaching, things like transport, equipment, also standing desks, like all sorts of things that you might find helpful can be funded through this initiative. One thing to say about trainees who are on rotation is that you have to be in your job, I believe, to access this and apply for it. And then if the waiting list is over 4 months and you're in a 4-month job, obviously that's not really going to be of much help for you because you have to start again with the next job. So yeah, seeing what you can do in practice rather than relying on these formal initiatives is equally important. Other resources for neurodivergent staff to access include practitioner health, particularly for mental health and burnout type symptoms, which are very common in the neurodivergent community. They can be very supportive and can not formally diagnose but point you in the direction of whether they think that you are neurodivergent and what assessment you should be seeking. And peer support for neurodivergent staff online is increasing. So I mentioned earlier about the organisation Autistic Doctors International, who are active on Facebook and Twitter and have a website, and they run WhatsApp groups and other support within their community for autistic doctors. There's also a couple of other Facebook groups, and there is support for nurses as well through the Royal College of Nursing. So there's definitely an increased awareness now of neurodivergent staff and the fact that they do need support and yeah, particularly from peers who understand what they're going through. So that is pretty much my presentation. I've just included a picture there of the newsletter that I've written, which has been sent out recently, which has got a bit more information. If anybody hasn't seen that and would like a copy, please let us know. But just to say really that I feel that awareness of neurodiversity and acceptance of neurodivergent people is key. Obviously accommodations are helpful, and thinking about that is a start, but also having senior role models has been shown to be really important for trainees and for medical students. So yeah, equally the senior staff talking about their experiences, I think, is another really helpful role that we can play. And as I said earlier, recognising neurodivergence and making accommodations in a practice and making a practice more neurodiversity friendly does benefit everyone. It's there are people who have sensory difficulties who are not neurodivergent, and that again would be helpful for them if their environment is friendly and accessible. So that's it. Thank you very much.
Thank you so much, Catherine. That was incredibly useful and certainly introduced me to lots of concepts that I wasn't aware of, and definitely around terminology to use as well. So it's an open forum now. Has anybody got any questions? You're welcome to put it into the chat or unmute yourself.
Hopefully that means I've answered everybody's questions already.
Exactly. Is it okay if I just share the screen, Catherine, if you just come off and
Yeah.
share the following let me just. So this event has been part of a wider EDI Lunch and Learn Empower Hour programme. So next month we're going to be joined by James Betteridge-Solby, who's a great advocate for the LGBT plus community. The day will be different, so it will be Thursday, same time, 12:30 to 1:30. He'll be going through an introduction of LGBT plus health in primary care, and then the following month we'll be talking about clinical care, and it's part of it's a 3-part series, and then he'll be finishing off in August. In June we've got a talk around allyship and active bystander training. Again, the time is the same, 12:30 to 1:30. A lot of what we're trying to do now is introduce you to lots of different concepts in equality, diversity and inclusion. So if you have got any comments or any feedback, then please do let us know. The email address for the office is here, and you can sign up for future events through the website or scan this QR code. Thanks again, Catherine, really useful.